occupational therapy. And I'm a third-year osteopathic medical student at the University of Incarnate Word in San Antonio, Texas. I also have with me Ms. Catherine Giesel. She can go ahead and introduce herself.
My name is Catherine Giesel. I have a master's in social work with an emphasis in macro policy administration and community organizing. I currently run a medical billing practice, and I work in compliance specifically related to documentation.
Thanks for being with us, Catherine. All right, so tonight we're going to get started with our agenda. We're going to cover a patient case introduction to kind of set the scene for what a patient situation and discharge planning might look like. We're going to then discuss an overview of the discharge planning process, just kind of an introduction to what that process is. Then we're going to take a deeper dive, taking a closer look at some of the details involved, and Ms. Catherine's going to share her background with social work and how they're intricately involved in a lot of those details that we have to consider. And then we're going to conclude with some tips for working together as a team and why discharge planning can really help our patients in the long run. To get started with our patient example, take Mr. Al Foster. He's a 71-year-old male, and he's brought to the emergency department in his rural hospital after his daughter and son-in-law noticed some changes. He sounded strange, he's hard to understand, and they're worried that he might be having a stroke. He comes in and receives care, and upon presentation in the ER, it's found that he has a left MCA ischemic stroke. He's then admitted, and the doctor initially brings on board a physical therapist, occupational therapist, and speech therapist. And this picture here is showing some of the roles that those therapists might be contributing to his care, and potentially why the doctor might have wanted to bring them on. So at this point, what we know is Mr. Foster's had what seems to be a stroke, and he's being assessed by his therapy team. Now, after this assessment, the therapy team is each going to write a recommendation for discharge. On initial evaluation, the OT sees that he's had a mild to moderate stroke, and they note some of the functional deficits that he's experiencing. So they're going to take that clinical picture based on what he could do before this medical event occurred and what he can do now, and suggest what they think that he might need for his long-term discharge plan. A few hours later, the physical therapist also evaluated him and noticed some changes in his clinical picture. He's performing a lot worse, his deficits seem more severe, and they're going to note this in their evaluation and discharge plan as well. So taking this into account, the doctor initially started with this patient who seems to be having a stroke and has now brought on these other professionals to help contribute to figuring out what's going to be the best fit for this patient now, and as his status changes, what might he need instead. Now, in this patient's situation, as you saw, his stroke was initially mild to moderate, and then it progressed to severe throughout the day. He ended up having a progression of his stroke. It had become hemorrhagic, and due to the involvement of several of the team members in his care, we were able to transfer him to the ICU and continue to treat his advancing needs. So given this clinical picture, we have this gentleman who's come in with a mild to moderate stroke. His discharge plan was initially probably different than now that it's progressed to include more severe deficits in ICU level care. So I wanted to start with this example just to show that involving several members of care not only gives you different clinical pictures as snapshots throughout the patient's stay in the hospital, but it also helps the plan evolve dynamically, because it's not just a one size fits all. You know, his discharge plan changed just that day with how he progressed. So it's really an ever-changing process that a lot of people are involved in. So that leads me to discharge planning. So what is it? And this is a topic we wanted to cover in this talk today because, you know, as having been an occupational therapy student and then an occupational therapist, and now as a medical student, I feel like something that I found challenging is that it's something that seems to be expected for us to just know, or something that we're expected to kind of pick up in our clinical rotations, but it's not something that we necessarily formally talk about. So whether you've seen it in practice so far or whether you'll see it in rotations coming up, Discharge planning is a process of creating a plan for the patient's transition to the next level of care. So whether that's a patient who's in a hospital and they're needing to create a plan for when they leave the hospital, or a patient who's already in a skilled nursing or rehab facility and they're needing to try to figure out whether that patient's safe to go home. This is a process that occurs at any facility level of care. So why is discharge planning important? Well, it's really important that we create an appropriate plan so it's promoting success for the patient. And like with Mr. Foster, the initial plan when he came in might be very, very different than his plan later that day or even a week after into his hospital stay. So being able to identify the factors that are going to determine what's necessary to consider for a discharge plan, what's going to make the patient safest, what's going to promote their long-term success for managing their condition. These are all important aspects that involve a team-based approach to be able to create the best recommendations for the patient. It's also important that we all know how to function as a team and move throughout this dynamic process, because it doesn't just stop after they leave the hospital. You know, it's likely if we have a patient like Mr. Foster who's had a stroke, that his care isn't going to stop, you know, a week after the stroke, after he leaves the hospital. This is something he's going to be working with for days, weeks, months, and probably years. So being able to set him up for initial good success, for him to be able to progress through those months and years of care, is going to help him be more successful in his rehab window. So I'm on my family medicine rotation right now, and I asked my attending doctor today what she wishes was contributed to family med. And she mentioned that another important aspect is involving the patient's primary care doctor in the plan. So letting them know when that patient has left the hospital or left a rehab facility, so that way they can keep track of that patient's needs and follow up with them to help reduce hospital readmissions and make sure their care is managed. Who's involved in this process? Like I said, it's often a team-based process and many times should be. This might include doctors of different specialties, different types of nurses, many different therapists, social workers, and most importantly, the patient and their family have to be involved in this plan. This plan starts on day one, and it progresses daily or weekly based on the patient's needs, and is often discussed at a daily meeting that you might have seen in practice, where everyone sits together and just shares updates on what that patient's progress is and what their discharge plan process is. An example of the interprofessional team might look like this. It looks like there's a lot of people involved, and there are. So it's important to know who does what on the team and what their roles are that they can contribute. Because each person involved in the patient's care is contributing a specialty, lens, and angle that they're trying to help that patient be successful and help the team be successful. So knowing who everyone is and how to work together can just improve involving the appropriate members of care at the appropriate times, and knowing better how to work with them when you're sitting down at these meetings and trying to prioritize what the patient needs at that moment. Now in the chat, we've included a little handout about what some of these basic roles are and what each member of the team might be contributing in this discharge meeting. So that's something, you know, I encourage you to save and keep for your reference, just as a quick guide to kind of remember what all of these people might be doing. I'll briefly go over them just to go over the overview of who might be involved in this meeting and what they can offer. So as many of us are familiar, a hospitalist is managing the whole team. They're often coordinating who's going to be involved, the referrals for specialists, therapists, making sure that nursing has the orders that they need. And they are the ones who are labeled as the discharging physician often on that patient's discharge paperwork. So if that patient were to be readmitted, for example, it could reflect on that doctor's metrics for hospital readmissions. And it's really important that that hospitalist or that doctor's on board with the whole team about when's an appropriate time to discharge and what an appropriate plan is. Specialty physicians might be involved, such as the patient's neurologist, the patient's surgeon, the patient's pulmonologist. And this would be appropriate to discuss if the patient needs additional care or an increased length of stay, or when the patient's safe to go home. Nurses and techs are involved in the patient's everyday care, and they can give information about whether the patient's able to take care of themselves, if they seem confused or have a change in status, and kind of give us a snapshot on whether that patient might be safe to consider sending home. Social workers or case managers, discharge coordinators, they often look into the patient's home and support situation. They deep dive into the patient's insurance benefits, and they can help fill gaps in care that the patient has. So, for example, if they're not covered with insurance, and they might be able to help the patient find a plan that they could qualify for to cover their next level of care or this stay. We've also got a team of therapists. The physical therapist is evaluating the patient's functional mobility and strength and endurance, and they're going to be really important to determining whether that patient's a fall risk if we were to send them home at this state, or if they would benefit from increased therapy before going home on their own. The occupational therapist is also contributing information about the patient's functional status. They're applying that functional mobility to activities of everyday living. So if we know Mr. Foster needs a walker to get around, can he use that walker to get in and out of the bathroom? Is he able to cook a meal for himself if no one's home to help him? So between your physical and occupational therapists, we're able to determine a lot of the potential needs for safety and if that patient's at risk of being injured or acutely readmitted due to their current condition. The speech therapist is also evaluating the patient's ability to swallow foods and liquids and communicate, and they can make recommendations for diet accordingly. For example, in Mr. Foster's case, he may have some dysphagia, so recommending an appropriate diet to decrease his risk of subsequent aspiration pneumonia would be an important role of a speech therapist, as well as helping him gain skills for changes in communication if he has some aphasia. The respiratory therapist can help determine the patient's respiratory function and if they have a need for supplemental oxygen at home, and then they can coordinate with the physician and with the social worker if that patient is going to need oxygen when they discharge home or to their next level of care to make sure that the patient's needs are covered once they get home. A psychologist might be able to contribute to understanding the patient's cognitive and emotional needs, such as if they had a significantly life-altering accident or condition, they might be able to help set them up with the needs with the tools to be successful and decrease risk of depression or anxiety once they transition to a lesser level of care, such as home or outpatient. Dietitians can help to make sure that the patient's receiving adequate nutrition and then set up a plan so that patient can still be nourished when at home. And then a patient intake coordinator is going to kind of work with everybody at that round table to make sure that everyone's voices are being heard, all of the needs are being addressed, and that the patient is getting that best plan of care that's attainable with their insurance benefits and their personal situation. And finally, the patient and the patient's family are extremely important to consider because each diagnosis and plan is not a one-size-fits-all. You have to consider the patient's diagnosis and if it's qualifying for certain benefits. You have to consider their medical history, their rehab potential, which is considering their prior level of function and how their current status is changed from their prior level. So for example, if a patient was previously living on their own, doing all their own grocery shopping, going to all their doctor's appointments, and is suddenly not able to even care for themselves or take care of their personal hygiene, that's a significant change that would need significant rehabilitation. Whereas if you had a patient who was already homebound and receiving total care at home, and now due to this condition is requiring more care, the change in functional status is less, so they're closer to baseline. And that's something where you consider that, there are things we could work on in rehab, but we're always trying to get them as close to their functional baseline as we can. So considering how much the patient has in their ability to work on is something that can help you choose what level of care is going to maximize that potential for them. You also want to consider a patient's preference if they have a certain geographic location or if they're willing or unwilling to go to a facility that they'd have to live at for a short period of time. and of course, their insurance and financial abilities to afford that level of care. Now, when you're involving the family members, you want to consider that patient support system. Do they have family that's around and able to help them in the days or weeks that they might need help? Is that family able to, stop what they're doing, whether it's a job or caring for their own family, to help the patient, or do we need to hire some type of additional outside help? These are all factors that I have covered in the handout, and that, when you're sitting at a meeting and you're trying to remember who does what on the team, can kind of help jog your memory. Now, when you're considering discharge planning from any setting, you want to consider if the patient's going to go to inpatient or outpatient setting. Those are kind of the two big categories. Most situations that you'll probably encounter, especially as a medical student, will be an inpatient type hospital setting. And you'll be considering, does this patient need inpatient care? As in, do they need a facility that they're going to go to and live at for days to weeks to months while they're receiving nursing and rehab care? Or is this patient at a high enough level that they're able to go to an outpatient setting, such as going home and then driving to a standalone doctor or therapy clinic for their needs? Now, the inpatient setting would include settings like a rehab hospital, a skilled nursing facility, settings that are staffed with nurses and therapists that are able to deliver care for some or all of the day. This setting is most appropriate for patients who are not able to safely take care of themselves at home, or that you wouldn't feel safe leaving at home for hours or days at a time, and that still need intensive nursing or medical care. In contrast, there's outpatient facilities. This is an option for patients who are safe to go home or have family that can help take care of them at home in periods between care being provided by professionals. Patients who are appropriate for this might be able to drive or ride in a car to an outpatient facility to receive therapy multiple times a week, or go to follow-up doctor's appointments. Or they might be considered homebound, where they're considered medically unable to travel for anything other than doctor visits and church. So in this case, if they qualified for homebound status, then they could have medical professionals such as nursing and therapists come to their home a couple of times a week to deliver care. Now, what's important about homebound is this is a unique situation where the patient is not quite needing an inpatient level service. They're able to be left home for some periods of time, but they have to be able to go hours or days between care being provided, because these professionals are not going to be in their home all day, every day, taking care of them. And it's important to remember at each of these levels of care, they're going to transition between levels of care, usually from higher acuity to lesser acuity. Which leads me to this chart. This is a chart that helped me a lot to kind of think about the discharge planning process when I was an OT student and as an occupational therapist and a medical student. And if you start on the left, there's an inpatient hospital level, which is where we're at with Mr. Foster. And as I was going over, there's kind of two choices. Does this patient need, an inpatient level of care, or do I think that they're safe to go home by themselves or with family and then travel to any follow-up care? So for Mr. Foster, when he initially came in, we might have been thinking, he could go home with his family and travel to his therapy, or maybe go to a skilled nursing facility. But due to the dynamic process of his discharge planning, as his condition worsened, we decided he might need a more intensive rehab stay, and then gravitated towards the inpatient rehab facility. Now, once he's at this inpatient rehab facility, he might be there for weeks or months, and then his team there would also be conducting a discharge plan for his next level of care, which could be a skilled nursing facility, or home with home health, or home to outpatient. So each of these levels of care is also going to conduct their discharge planning process to help that patient transition longitudinally throughout their care. And I'll pass it off to Catherine to take a deeper dive into documentation and discharge planning.
Do you want me to share my screen, or do you want to just click through it as I get through the slide? I didn't think to ask that.
I can click through it.
Okay, cool. So, kind of in keeping with what we were just talking about and these different levels of care, what's going to be, most crucial in terms of reimbursement and documented improved patient outcomes is what does this patient look like? And it sounds really kind of broad and abstract, but that's basically what documentation is. What does that patient look like? What does the lab say? What do I know this patient needs? And how do I best advocate through these levels of care to ensure that this patient discharges appropriately and has the best outcomes once they go back home? It's kind of cliche, but it is true that discharge planning begins as soon as the patient is admitted. That sets the stage for everything that's going to come forward, from documenting the patient's PCP to the date and time that they came in. Insurance can be really fickle when it comes to that. So it literally is from the second the patient walks in, you start that discharge plan, and then it just stays fluid. It stays something always changing. It stays something always advancing with the patient. So if the patient moves forward, the discharge plan moves forward. If the patient has a setback, the discharge plan there goes back a step. That initial admit really does kind of set the stage. It also gives practitioners information about the type of coverage the patient has. What type of support? Did they come in on their own? Did family bring them? Was it an emergency admit? You can learn a whole lot from that very first initial admit document. It's also used documentation to maintain a level of care. So as long as you're documenting everything you see, hear, understand, the documentation should be complete. The best thing about documentation, especially in a closed system, if you're in an inpatient hospital, is everybody gets to read what's in that record. So the more information you can provide and the more complete that information is, the more quickly other team members are able to move and help support that patient through this transition of care. Obviously, the best, what we're looking for is the best outcome health-wise in the shortest amount of time. It sounds a little bit harsh, but that's the goal. We know patients are healthier the less time they're in the hospital. So if we can get them healthy and get them moved step by step, then they have better outcomes in the long run. And a thing that I'll touch on again when I talk about insurance, but all payers, Medicare, Medicaid, all insurance payers are going to require thorough documentation for transitioning levels of care. So why is this patient still inpatient? They want to know that they're getting better, but not so much better that they need to leave. They want to know, or this patient has met all of their goals. Now we want to transition them to an inpatient facility or a live-in residential treatment sort of center, where then it's going to cost that insurance provider actually more because it's a long-term commitment. So what they're going to do is look at why is this necessary now? What's the next step so that this patient is closer to going home? Basically, just how do we get this patient to the least restrictive environment while supporting the best outcomes? And documentation is really the only way that they're going to extend or change a stay. It's also the best way to communicate amongst team members. Every team, every specialty has kind of their own language, and a universal documentation, form of documentation and discharge plan help support all team members. So those crucial daily meetings is kind of where all the different specialties jargon comes together in one, and you view the patient kind of as this whole, and then all those moving pieces of that circle get to work together to provide the best documentation and support to move that patient along through their recovery. Like I mentioned with insurance, so reimbursement for services rendered is dependent upon documentation. You can provide services all day, and insurance may even pay you. But if they go back and decide to look at your records, they have all the right in the world to take that money back. And if you're at the top of this, transitioning of level of care, and they decide, no, we didn't like this person's documentation, they can then go and take the money back from providers underneath them. So it really is, every little piece of documentation is dependent upon the one before. Most insurance companies now will require authorization to provide care, transition care, and anything that's incomplete or inaccurate will ultimately usually result in financial penalty and potentially corrective action against the physician that documented, that did the documenting. So you can go to the next one. So again, we talked a little bit about this transition of care. The big thing is the smoother the transition, the better patient outcomes we have. It also reduces the burden on the patient's family and the support system. So this family has also been thrown into a whole new world. And the more support that can be given from their care team, the more likely that that family is going to be able to provide the emotional support and physical or financial support that this patient may need. The more burden we place on the family, the more likelihood, increased likelihood for readmission and for, almost like a relapse in their transition of care. So again, insurance is going to review everything documented, and it will impact the insurance reimbursement all the way down the line. Another important part in this transition of care is that it improves the relationship between the interdisciplinary team. So people don't want to read bad documentation. They don't want to go back and have to ask the same questions to an already uncomfortable patient or family member. So the less burden you can put on the patient, the family, and the less stress you put on your coworkers or other members of the team, the better overall. Also, it reduces duplication of efforts, which is not billable by two people in the same day. So if there's a history and physical done one day, or and it's a follow-up visit, it's 15 to 25 minutes, two doctors can't bill for that in the same day. So that one doctor that gets to bill for that needs to document it effectively enough that all of the other providers, I don't mean doctor, I should say practitioner, so that everybody gets to read the same information and nobody's kind of being left with the short end of the stick when it comes to what they're able to do for that patient. Another big thing is obviously compliance. Documentation is a requirement and thorough documentation, not only with the facility, with your employment contract, which you will have, but CMS, Medicaid, workers' comp, all major payers, your documentation is your word. And if it's not documented, it didn't happen. So it can't be defended if there's any legal action taken, if there's a lawsuit, if there's a board complaint. The safest thing to do is just document everything you have, create a comprehensive discharge plan, kind of cover everybody along the way by keeping everybody involved the whole way through the process. So yeah, the more hands you have in the plan, the better, so long as everything that's in there is accurate and thoroughly documented. So these are some situations that make everything that I just mentioned a little bit more difficult. And this is also just kind of the nature of working with humans. Everybody's not always going to be perfectly insured, speaks English or from a city and has access and family and all this. That's typically not, the case. So these are just some specific situations, some vulnerable populations to keep specifically in mind when you're looking at discharge planning, because it's not going to be so cut and dry. There's not going to be a basic form that's going to work for everybody. That's why that initial intake can be so important, because you learn a lot of this information and you can start working with social work and resources in the community and with finances in the hospital and try to figure out how are we going to do this for this particular patient. Obviously, unhoused people are somewhat difficult when it comes to follow-up care, primarily the lack of address, phone number, and identification. State Medicaid will not insure a patient that does not have a permanent address in the state that I'm in. They also require that you receive communication either by phone or by email. So that automatically poses a huge issue. This is when kind of advocating for a more inpatient or residential approach would be what I would recommend when it comes to an unhoused person, because there is no way to guarantee that there's going to be any compliance with the plan. And it's not, on the provider to necessarily advocate for that, but to be aware that this is going to be the best situation for a positive outcome. Transportation is an issue, obviously, across the board with a lot of people, but specifically with unhoused people. And then we can go to undocumented workers, has very similar kind of issue when it comes to a permanent address, phone number, email. language barrier, and then also obviously current federal policy or state policy that dictates whether or not an undocumented worker can or cannot be insured. There are a lot of community resources available that will help with these populations. And, part of the job of as a provider is to learn what's available for your community, because making a recommendation or, transitioning care and working on discharge planning is only as effective as your ability to deliver that information to your patient. Or to communicate that to the social worker to deliver that to the patient or to the psychologist, or whatever the next step is. Having an understanding of what's realistic and meeting that patient where they are, which I know is also a little cliche, but it's really important when it comes to vulnerable populations. Again, with refugees, a big one is going to be cultural differences. And that's something that does take some training and experience, really, but understanding the expectation of, male, like gender roles in different cultures, and so like social norms, and, who's the caregiver, there's very delicate kind of moving pieces to the refugee population. But fortunately, there are tons of organizations in every state across the US that will specifically help with healthcare for refugees. The IRC is a good option. They're everywhere. But just having a little bit of understanding of where that culture lies and kind of how receptive they may be to this kind of top-down healthcare system that we have, which can be very oppressive to some populations. And also case manager. Obviously, with the refugee, you won't only have your social worker and hospital or physical therapist or OTs, but they will have an assigned case manager under their refugee status. So ensuring that somebody's getting us like in touch with their case manager and ensuring that this kind of full circle of support in the discharge continues once they walk out those hospital doors. And then these are some of the ones that I think some of us are a little bit more, familiar with, the cognitive issues. And this is obviously something that would be assessed upon intake. And this isn't just for, what the patient was experiencing prior to the onset or to the incident, or the admission, I should say. But this could be, how did their cognitive ability change? What's different now? Is there, some more support or different support? Is this a whole new arena that this patient's never had to kind of navigate? And then there are the pre-existing, they have a developmental disorder, mental illness, or a really low literacy level. Something that we often take for granted when it comes to, being in the hospital setting is that not everybody can read the forms that we just take as second nature, that we just believe this is it, fill it out, no big deal. Sometimes it's not in their language. Sometimes they can't read. Sometimes they aren't able to verbalize, even emotion. So it's really important just to keep in mind where that patient's at and who is the next person to call. So cognitive, you're like, is this new or late? Maybe I check with neuro, or, oh, I got to check with social work, or maybe a psychologist could come in. But just kind of understanding that impact on the discharge kind of cycle. I kind of look at discharge planning as just like a circle, and it just continues. And sometimes you go back and forwards, and it's never, it's not uniform, and it's definitely not linear. So another one would be the community. Is there a specific religious belief? Do they live in a rural area without access to these resources? Do they have any support out there? And basically, how do they feel about having to, go back to doctors all the time? And what is that support going to look like from, within the world that they live in, not the one that we decide that they live in? And then lastly, geriatric population. This could have been its whole slide in and of itself. This is a huge area of interest right now when it comes to discharge planning. It's actually where I found most of the research focused right now because of our aging population. There's kind of been a big push to figure out, how are we going to keep this huge group of people from just sitting in hospitals? Because without the right social supports and without social services, that's ultimately what would end up happening. And then they would be discharged without a plan, end up sick and back in intensive inpatient care. So again, that would be, do they have a caregiver? What is the caregiver's ability to care for them? Can they fill out the forms? Do they know how to distribute medication? Are they able to drive a car to take this elderly person to appointments. And then again, social work is going to be key here, kind of going back to that access to resources. There's been a huge push in geriatric social work. So I would highly recommend anybody interested in the geriatric population to look into your local area agency for aging. That's what it's called in my state. But it's like APS, like Adult Protective Services, but it's done through nonprofit funding, or grant funding. So there's a lot of cool organizations that are out there right now that are providing support specifically for these situations with geriatric patients who are leaving a higher level of care and don't know what to do next. So that's that one. And insurance factors, everybody's favorite. I'll try not to be dark about this one. And I'll kind of I'll stay pretty upper level on it. But so insurance factors, these are going to be things that you won't have to think about on your day-to-day, but it's something that should definitely stay in the front of your mind, because if you do end up in private practice, or if you do end up billing outside of a major facility, these sort of things are going to drive you crazy, and they are going to be the way that you get reimbursed and ensure your patients the best care. So when it comes to documentation, authorization for transition of care, any movement, like I said earlier, between providers or facilities is going to be directly impacted by the documentation. And that transition of care for that patient and that discharge planning is crucial to their health outcome. So in the very beginning, like I said, with that first admission, your financial office, wherever you're working, is going to start on getting these authorizations for care. So they get the emergency admit because you can't say no to an emergency admit. And then from that moment forward, every other procedure is based on the documentation provided to the insurance specialist or your front end. So from there, that's the transition of care, which is key, because everybody down the line is going to read that same information, and it's forever going to be associated with that admit date. So that is going to determine, like I said earlier, that documentation all the way down. It has like a trickle down effect to all of the providers that sit at the very bottom, from the last physical therapy appointment the patient has when they get their final discharge. They're finally done, they're cleared, they're back to whatever functioning status that they're able to attain. That documentation will follow them the entire way. So it's crucial to get that right from the beginning. There's also the issue of prior authorization. Again, something that's not going to be usually directly the responsibility of the provider. However, you can order a treatment all you want. If your back office can't get it authorized because the documentation isn't good, your facility is not going to authorize the treatment. So you're putting your patient in a worse position because the documentation wasn't effective. And I'm not saying to exaggerate it, but I'm saying to know the guidelines for these different insurance payers, know exactly what it is your patient needs, and be familiar with what's happened before. So showing a change in patient status is crucial, whether positive or negative, is crucial to getting prior authorizations. And technically, prior authorization does, quote unquote, guarantee reimbursement. But the request for reimbursement has to perfectly match the documentation on the patient and the documentation from every other provider that day. So the facility has to document the same as the hospitalist, same as the anesthesiologist that put them to sleep for a pain block. All of that coding or whatever it is needs to match. Otherwise, they're going to deny. And then comes into the denial and appeal management portion. And this is when there is a denial, which happens, and they will happen. The only way that that's able to be challenged is through documentation and defending the position in the documentation. If it's not documented, it didn't happen. And I'll say that probably a few times, but it's crucial to understanding how insurance works and how to most effectively transition patients through discharge planning to lower levels of care. And again, there are payer-specific requirements, state-specific requirements when it comes to the way this documentation looks. So I highly encourage everybody to take a look at the major payers in your area, and even maybe make a friend in the finance office, and they'll tell you, this is what doesn't work. This is what does work. This is the issues we're seeing, so that you can then kind of be an active member of that team. And that feeds perfectly into that.
So speaking on that, as Catherine mentioned, there's a lot of moving parts, such as getting to know who's on your team, what their expertise are, and what they can offer you. So for example, if you need to learn more about insurance and you're not quite sure the terms, this is a good opportunity to, like she said, make friends with someone in the billing office or with your friendly social worker at your facility and get to know what their expertise is in that field and how you can grow from it and improve your practice. So when you're working with any member on the interprofessional team, from that graph that I showed you earlier, that handout, there's a lot of different professionals on there that each have specialized training and use their own language to address their specific lens and what they're trying to accomplish with that patient. And being able to work with them is really going to make a strong difference, both in how you collaborate throughout that patient's care and as you're beginning to hand them off to the next level. So for example, if you're giving a verbal handoff to the next physician, or if you're writing documentation that you know is going to be read by the next level of care, making sure that you're getting those key messages across so that way they can pick up where you left off in a timely manner and hit the ground running to really continue that patient on their recovery track. Some tips that I really like for whenever I'm working with someone, especially someone I haven't worked with before, or maybe I'm not quite sure what they do on the team, is to identify and involve the appropriate people. So that's knowing who they are, not being afraid to ask, what their role on the team is and what they can contribute for this patient or for their care. And also importantly, what they can and cannot do for that patient. So what their scope is and when you might need to involve that next level of care because it's maybe beyond their scope. It's also important to be understood. And this just takes practice using language that you have in your field and then also that you've accumulated by working with other professionals. So as you accumulate a vocabulary that you can use with social work and with rehab and with nursing, using that language to provide adequate information that's concise and clear and situationally appropriate. So that way the best message is making its way not only to that individual, but to the next individual that they pass it along to. It's also really important to collaborate, act, and reassess. So when you're working on any team, even a sports team, being able to talk about, say in sports, how the play went that day, what the outcome was of it, and how we could do better. We can do that in healthcare too by discussing and creating a plan of action as a team, determining who's going to take what role on conducting that plan, and then following up after that plan's been done to see what worked well, what didn't work well, and what can we do better next time we're also working together for our next patient. Something that I found that I liked when I'm working in a hospital setting or a rehab setting is some type of system to help the patient understand their care needs and how that's going to change throughout the continuum of care that they're going to receive. So like Catherine was saying, this is a cycle, it's an ongoing, ever-changing process. And being able to proactively address the needs of the patient is going to help set them up for success in their hospital or rehab stay and as they move to the next level of care. So as a medical student or any other type of student, we seem to have a little more time than the attending or resident physicians. And this is something that we can do or encourage other students once we're supervising one day to do to help that patient to be more informed and more prepared. This is a link to a stroke discharge checklist that I found that I like that covers questions that the patients might not know to ask or might not think to ask when the doctor or the team of residents is in the room. That could just help them be set up for what to expect kind of when they go home. This one's for stroke specifically, but this is something that can also spark a conversation for any condition the patient has or new diagnosis or life change that the patient has, just to help them prepare for what they might need to be thinking of or acknowledging for their next levels of care. Overall, rehab is a long-term and ongoing process, and by working well together, we can facilitate that our patients are moving smoothly and in a timely manner through each of these levels of care and not, leaving the hospital and then not getting to their next rehab appointment for 2 or 3 months and missing that crucial window. We want to be able to set them up for success and a smooth transition through all levels.
I think it's just the main goal is to how do we get a patient to where they want to be or where they can be. And I think that it's complicated because of so many moving parts, but at the end of the day, I think we're all in this system and we're all working in healthcare for that end goal. And I think reminding ourselves of that and working with other providers, like you were saying, what is your role here? What isn't your role here? Kind of establishing that idea that the end goal is to improve the patient outcome, and to do so the most effectively is to discharge plan together as a team. I mean, it makes perfect sense. You don't get to graduate college without your transcript. You have a set outline of goals you have to meet to get out of there. And it's kind of in a similar sense, that's a little bit what recovering from, one of these major admissions may be like. It's just a series of small successes and checks and balances. And the people that really kind of guide you through that are going to be the providers that are in that, the big team. So, all of that aside, one of the basic reasons that, good discharge planning improves outcomes is obviously patient satisfaction. The patient's going to feel listened to. They're going to increase their likelihood of compliance with the team and the treatment plan. The family and social support systems will also show up more if they believe the patient was satisfied. Patient satisfaction is also incentivized by Medicare. So they're doing a lot of outcome measures done through a bunch of different reportings that shows just how important patient satisfaction is. Medicare is going to pay you for it. They will also penalize you if it goes too low, but it's a really huge indicator of a reduction in readmission and increased health outcomes. So again, readmission reduction is also incentivized by Medicare. So if you can show that patients aren't coming back, you can show that they're meeting their health outcomes, their goals, and you can show you're spending less money on the same patients over and over again because there wasn't an effective discharge plan in place. That's also incentivized by Medicare. Functional status, I think that's the big one. It's the one that kind of pulls on the heartstrings the most. Mental health improves with support and direction, which is guided by the discharge plan. Physical outcomes as compared to those discharged without the team support and comprehensive discharge plan. Less burden on family and support systems, which also increases the likelihood of a positive outcome and reduces the readmission rate. And it gives the patient the best chance to return back to whatever their functioning status now may be, whether it's what it was before, whether it's a new one. It allows for the patient to have some self-determination within their treatment while utilizing the expertise of all of these team members that have supported them through this, journey. And then again, the continuity of care, and this is a little bit more on the finance side I went with on this one. It reduces duplication of services and it avoids errors. So if you're not thoroughly documenting, there's some really bad stuff that can happen to patients. And it's important that everything is documented and transitioned between all levels of care and everybody in that team. Again, the main goal is just improve patient outcomes in the least amount of time with the least likelihood for readmission. And discharge plans directly support that. So that's that.
And that leaves us with any questions. If anyone has any questions they'd like to share, we'll be available to answer those. Otherwise, thank you all for coming, and we appreciate your attendance and have a great evening.